It's probably the #1 reason why athletes aren't able to do their athletics, because they have an injury to the knee. And it's actually pretty easy for a person to figure out themselves whether or not they're a prolotherapy candidate. So I'm just going to go over a few of the most common conditions that we see here at Caring Medical. Like right now, right there is the joint line of the knee. And folks who have pain on the joint line here often have a meniscal tear, or they have an injury to the meniscus. So anyone who has like really spot tenderness on the inside of the knee has to think that they got a meniscal injury or a meniscal tear. This is actually feels worse when a person squats or they run. So in other words, they could maybe walk normally, but when they run or they squat, they'll have really severe pain right on the medial joint line. Prolotherapy works great for meniscal tears. Actually, if somebody goes on the internet, we did a study of 28 people who had documented meniscal injuries, and 27 of them healed with prolotherapy, and only 1 with a meniscal tear needed surgery. So that's great results. Probably, though, the most common knee condition that there is actually called patellofemoral tracking syndrome or chondromalacia. Patellofemoral tracking syndrome normally, or it does indicate that the patella, this is this person's patella, and this is a young athlete. You could see that even in this position that her kneecap is a little bit lateral. So patellofemoral tracking syndrome is where the patella doesn't track normally in the groove on the femur bone. Normally it's supposed to track in the middle, like when the person walks or they run, the patella is supposed to go up and down here right in the middle. People often, because of muscle tightness and various things, have their patella track laterally. And this wears at the cartilage underneath the kneecap. When the cartilage gets worn out, it's called chondromalacia patella. Chondro is cartilage, patella is kneecap, malacia is damage, so damage beneath the kneecap. So when your kneecap is tracking wrong, you actually get cartilage deterioration underneath the kneecap. So traditionally in physical therapy, you'll do strengthening of the vastus medialis muscle, which would pull over the kneecap. How we strengthen that is just have people cycle. So part of the protocol that we use here at Caring Medical is to have people bicycle ride and then do strengthening exercises of the vastus medialis. Also, we do prolotherapy. We mostly do prolotherapy on the inside here to pull the patella medially, and then we do prolotherapy in the joint to stimulate cartilage repair. And obviously, if there's other tender points like the patellar ligament or patellar tendon here, we'll also do prolotherapy there. We are in the process of writing up a study, so we have data on around 70 clients with this condition, and the results are spectacular. Like, the results are way better than any other therapy, physical therapy, surgery for patellofemoral tracking syndrome and chondromalacia. Another common condition that we see, especially in runners, is called runner's knee or patellar tendinosis. There's a structure that goes from the patella or kneecap and attaches here onto the tibia. That's called the patellar tendon. It actually should be called the patellar ligament because it really goes from this bone to this bone. Now, normally the person is very tender here, where that tendon attaches to the tibia here, but it can be anywhere. It can be tender or painful in any area along the patellar tendon. When you do an MRI or you do a biopsy, often the tendon will be very degenerated if the condition has gone on for a long period of time. Obviously, a degenerated tendon needs regeneration. So obviously I'm a proponent of prolotherapy for patellar tendinosis or runner's knee. Now, it's pretty common nowadays for me and our office to see clients who actually have already received PRP, because there are orthopedic surgeons doing platelet-rich plasma for this condition. And the reason that they don't get better is when I examine them, and I'm just going to illustrate it right now. You know, when you do this test, that's called an anterior drawer sign. That's a test for the anterior cruciate ligament. So when someone has patellar tendinosis and they've had some prolotherapy on the patellar tendon, or they had platelet-rich plasma type prolotherapy to try to stimulate the tendon to repair, and it just seems like the person's not getting better, it's probably because they got joint instability. In other words, they have injury to the anterior cruciate ligament inside the knee, and that's why the patellar tendon isn't getting better, because the joint's unstable. So in other words, if the knee is moving too much, the tibia bone is moving too much on the femur bone, that's going to put additional strain on the patellar tendon. So you actually have to tighten the ligament along with strengthening the tendon. So you need prolotherapy into the anterior cruciate ligament or whatever ligaments are stretched or lax, along with treatment to the patellar tendon. So since we're talking about the tibia, there's a bony prominence here called the tibial tubercle. It's very common in children or young athletes to have a pain in that area. The most common condition that causes that is called Osgood-Schlatter disease or Osgood-Schlatter syndrome. There was a really good double-blinded study to show that dextrose prolotherapy absolutely was helpful for Osgood-Schlatter. So all you have to do with Osgood-Schlatter is actually do prolotherapy where the patellar tendon or ligament attaches to the tibial tubercle. So in a young person, you're really just doing prolotherapy in this region and, you know, getting that structure very strong, and then Osgood-Schlatter, you know, the pain goes away. I mean, the normal treatment for Osgood-Schlatter by an orthopedic surgeon is going to be rest, you know, and athletes, like, they'll miss whole seasons. And all that's going to happen is if you rest something, it's just going to get weaker, and the athlete's going to miss the season, and the athlete's joint's going to get weaker. We would prefer to get the structures stronger, they get back to their athletics quicker, and then long term they don't have any problems. Now, having gone over these conditions, obviously the condition we see the most in the office for the knee is either joint instability or osteoarthritis. So the person, you know, especially if they're, you know, say over the age of 40, when they have diffuse pain, like often people say, "Doc, I'm just telling you it's underneath there." Like it's underneath there, you know, underneath the kneecap. Well, if it's underneath the kneecap or if it's behind the knee, most likely it's going to be inside the knee, so they have an inside the knee problem. The most common inside the knee problem is going to be osteoarthritis. So with osteoarthritis, normally when I examine the knee, they won't have full range of motion, and the person will have some stiffness when they sit too long. And the stiffness is because they don't have the normal amount of joint fluid, and that's part of the process, the degenerative process. Like the body doesn't have the normal amount of oil or joint fluid in there. Why people very quickly often get better from prolotherapy for knee arthritis or arthritis anywhere in the body is that prolotherapy causes the synovial cells that make the joint fluid to produce more joint fluid. And often, because, you know, think about it, like I've had lots and lots of clients, I do prolotherapy in the knee, you know, they've been told they need a knee replacement. Then they say, "Doc, I'm just telling you, on the way home I already was better and I've been better, you know, since I've gotten treated." Well, that can't be because of cartilage growth. Like you don't get instantaneous cartilage growth. It's because they started making joint fluid, and that joint fluid is actually the most important cushion in the joints. It's not the cartilage. The most important cushion in the facet joints, the ankle joint, the shoulder joint, the knee joint is actually the joint fluid. So prolotherapy is a spectacular treatment for knee arthritis. In our office, we have about a 90% success rate of helping people not need a knee replacement, you know, when they're a good prolotherapy candidate. The cause of knee arthritis, though, is actually joint instability. So I would prefer to get young athletes, like this young athlete, when they have joint instability, to resolve the joint instability so then they don't develop knee arthritis. Like that would be the best case scenario. So if somebody has, pain on the side here, this is where the medial collateral ligament is, or if they have pain diffusely on the other side, that's where the lateral collateral ligament is. Then they have ligament injury. Ligament injury causes instability. Instability just means that when the person's walking or moving, there's an excessive amount of motion in the joint. So that's all instability means. There's an excessive amount of motion of the joint causing symptoms. Because, there's people that are loose jointed. They're just born with loose joints. They might have hypermobility of the joint, but they don't have symptoms, so the joint isn't unstable. When a joint's unstable, so we're talking about the knee joint, when the knee joint's unstable, basically 3 things are going to happen. Well, 4 things. When the ligament is under too much tension and it's stretching, the person's going to feel pain. The ligament is the sensory organ for the joint. So in other words, what's going to tell the joint that the joint's under too much stress? Whether it's playing basketball or running, it's going to be the stretch of the ligament. When the joint becomes unstable, it's very, very common for the joint then to swell. The swelling, so if somebody has chronic swelling of the joint, it's because they got joint instability. They have joint instability, and the swelling's causing the joint to become more stable. So the treatment shouldn't be taking an anti-inflammatory to get rid of the swelling or get a cortisone shot. It should be, let's do prolotherapy to get the joint stable, and then you stop the joint swelling. So that's why Dr. Hauser is very adamant against anti-inflammatories and cortisone shots, because it doesn't get at the root cause of the problem. Then what happens is the person exercises, they're exercising on an unstable joint and they can't feel it. They're playing basketball like, oh, this medication is fabulous, I can play basketball. But now you don't even have the protective mechanism that allows your joint to get swollen because you're taking an anti-inflammatory. That's a very dangerous situation. You're just gonna get worse. So when you have joint instability, basically the body's response is threefold. One, it's going to recruit muscles to stabilize it. So then you can get muscle spasm. This especially happens in the back and the neck, not so much around the knee. What happens in the knee joint is the knee joint swells. If you don't resolve the joint instability that is causing the knee to be painful and swollen, what's going to happen is the body's going to overgrow bone. The overgrowth of bone is bone spurs. So if a person has, the doctor did an x-ray and it showed like, geez, you got some bone spurs. I'm just telling you, the cause of those bone spurs forming was joint instability. So the treatment of choice should be prolotherapy. So prolotherapy, by stimulating the ligaments to repair and tighten, and by prolotherapy, just know that I mean it's an injection technique that stimulates the repair of ligaments, tendons, cartilage, meniscus, and it does so by the proliferation of cells. The word prolotherapy is proliferative therapy, so we're proliferating the cells that make the various tissues. So when we talk about doing prolotherapy for ligaments, the cells that make the ligaments are called fibroblasts. The cells that make the meniscus are called fibrocartilage cells, or fibrochondrocytes, and the cells that make the cartilage are chondrocytes. So when we say prolotherapy, we're proliferating chondrocytes to make cartilage, fibrochondrocytes to make meniscus, and then fibroblasts to make ligaments. So obviously, if we're making new ligament or stronger meniscus or stronger tendon or stronger cartilage, I mean, it's going to help a lot of conditions. So prolotherapy is extremely effective for chronic knee problems, and I'd really encourage people who have a chronic knee problem to get an evaluation for prolotherapy.